Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols. We are back. Let's do a case study. This was the ubiquitous middle of the night little old lady with chest pain call. The patient was an 84-year-old female. She reported that she was woken out of her sleep with severe chest pain that radiated to her back. I am sure that is setting off alarm bells for many of you. Granted, you can't make a diagnosis just by one piece of information, but already with this limited bit of information, I bet that some of you are probably thinking aortic dissection. I have covered this topic. This is actually one of my favorite topics. I covered this in an episode called Rippin' Aortas. And in that episode, I go into pretty significant depth with the pathophysiology and how you treat these patients. I'm going to cover a little bit of that here, but not as much in depth. This is a case report. We're going to talk about how the call progressed. We're going to touch on some learning points, which are going to touch on some of those things that I covered in that episode. But if you want the deeper and the finer learning points, listen to Rippin' Aortas. It was recorded in April 2023, if that helps with you finding the episode. So, BLS gets there first. I arrive on scene. I am by myself as a paramedic as I am in my single medic chase car. It was a lovely residence, actually absolutely gorgeous residence, a Civil War era house, immaculate inside. You can tell that this lady, despite being of advanced age, was living her best life. Lovely patient, but she looks like death. She's pale, she's clammy, she's drenched in sweat, and right there, right off the bat, you can tell that something is seriously wrong with this lady. I was telling a student just the other day that now, almost a quarter century into my career, I have come to the conclusion that pallor and diaphoresis is one of the more alarming findings that I find points to serious badness happening with the patient. Now, this is not absolute. EMTs don't go jumping up and down and screaming if you have a patient that's pale, clammy, and diaphoretic. And paramedics, if you have a patient who's pale, clammy, diaphoretic, don't go driving at Mach 3 to the hospital just because I said that. Not that you would listen to me. But you can get pale, clammy, and diaphoretic from benign-ish symptoms. Certainly. The 14-year-old with vasovagal syncope will look like death. They will have pallor and diaphoresis and be quite perfectly stable. This happened to my daughter just a couple of weeks ago. Right after the call that we are talking about on this case study today, the next call I responded to a patient who was indeed pale, clammy, diaphoretic, looked like shit. She was rock stable. She called 911 after having 5 hours of nonstop diarrhea after eating eggs that she suspected were bad when she was eating them. Why she ate them, I don't know, but she was fine despite being pale, clammy, diaphoretic. I had the man flu a couple of months ago, and I was pale, and I had a sweaty brow, and I was fine. Hangovers will cause pallor and diaphoresis, so it is certainly not a definitive thing, but if the patient is not experiencing what I would call, I'm trying to think how best to put this. Some might disagree with me for putting it like this, but if it's not a lowball complaint and the patient is pale and diaphoretic, then that is a significant finding for me. So if the patient is short of breath and they're pale and they're clammy, that's alarming to me. If the patient has suspected GI bleeding and is pale and clammy, that's shock, plain and simple. I don't really need more assessment to tell me that the patient is in shock and is seriously ill. And certainly pallor and diaphoresis are very significant findings in the patient with chest pain or other cardiac symptoms. I would argue that if we are talking about simple head to toe, not using diagnostic assessments, one of the most significant physical assessment findings is pallor and diaphoresis. In the patient with a cardiac complaint, it is a significant predictor of badness. And you can go on PubMed and find lots and lots of supporting information on this. I've touched on this in previous podcasts. So this lady is very pale, and she's not just diaphoretic, but she is drenched in sweat. She was 84, but she was one of those 84-year-old women who you could tell was baseline in pretty good shape. I'm not trying to say that she was a gilf or anything, but you could tell that she was a quite attractive 84-year-old lady who took great pride in her appearance. She looked like death. Her hair was drenched. So the fact that she looked so bad, that was another alarming finding for me. She was wearing a bathrobe that was wet from her sweating through it. You could tell she had put on mascara earlier in the day. That was kind of running down her face. Definitely alarming looking. So as far as history, she tells me that she's woken out of her sleep with this chest pain that since calling 911 has now moved to her back, and she used the word tearing. No bueno. If you are a novice, the learning point here is that chest pain with radiation to the back and described as tearing or ripping you often hear, that highly suspects that the patient is experiencing an aortic dissection. And I'm not trying to impress myself here or impress you when I say this, but when I walked into her house, took one look at her and heard the terms in my back and ripping, I knew right then and there that she was probably having an aortic dissection. She likely was going to die, and that there was a damn good possibility that that was going to happen during my time with her because we were 40 minutes away from the closest appropriate hospital, which was one with CT surgery capability. But while I strongly suspected it, and I did end up being right, you just don't know. She could have been having a STEMI. She could have been having a non-STEMI. We don't have POCUS at my service yet. I think that certainly would have been useful, no doubt. Further physical assessment yielded tangible JVD, another significant finding, which indicates venous congestion and elevated pressures in the heart, a dysfunctional heart. Surprisingly, her vital signs were picture perfect. Her GCS was 15. Respirations were in the 20s, normal pulse ox, heart rate was in the 80s, normal sinus with no ectopy. That kind of surprised me that her rate was so low. I figured maybe she was on beta blockers, but she was not on beta blockers. Why was she not tachycardic? I don't know. It just goes to show that patients don't always fall into that nice wrapped up textbook package that you learn about. And her blood pressure was 140/90. I did not like her blood pressure. Why? Because I suspected that she had an aortic dissection, and these patients typically have a very high blood pressure. They're in severe pain. They get a reflexive increase in blood pressure when that aortic intima tears. Is it intima or intima? When the aortic tissue tears. I have transported a lot of aortic dissections at my other job on the helicopter, and these patients are often on both esmolol infusions and nicardipine infusions for blood pressure management because you want to aggressively take the blood pressure off of that ripping aorta and lessen the potential for that tear to get bigger and rupture. And even despite being on those infusions, you are often pissing into the wind with your antihypertensive management. They often will still have blood pressures, 180s, 200s, even despite being on those infusions. So 140/90 to me seemed like maybe there's a lot of damage already done. Maybe she was already on the way to decompensating. Maybe the dissection has ruptured and she's now leaking blood into her chest. But right now, let's not overthink it. For right now, in the grand scheme of things, the blood pressure is okay. So what is next? Well, obviously, I think most of you would agree, a 12-lead EKG. I hook up the 12-lead EKG and lo and behold, nothing comes up. The 12-lead cable's crapped out on me. I thought maybe it was a contact problem as she was so sweaty, so I took off the leads, I dried her chest, I rehooked up new leads, and still, it was a monitor problem. I said, fuck it, no sense wasting time on scene troubleshooting cables when she's this sick. And I asked the BLS crew to grab the stair chair, because certainly we are not going to walk this patient. And just as I asked them to grab the stair chair, she winced, she grabbed her chest, she said, it's getting really bad. She then began to twitch, developed a 1,000-yard stare, and went unresponsive. The monitor then showed a normal sinus rhythm, narrow complex. I'm sorry, I shouldn't say normal sinus rhythm. Showed a sinus bradycardia, normal narrow complex, rate of around 40. And then quickly that went into a flat line. Oh, crap. So the EMTs and I moved her from the chair to the floor, laid her flat. She is agonally breathing. I'm about to start compressions, and I look at the monitor and I notice she's back in a normal sinus rhythm, narrow complex in the 80s. I check a carotid pulse, which I hadn't done yet since lowering her to the floor. Granted, it had only been like 2 or 3 seconds. And I feel that she has a very, very weak but palpable carotid pulse. No radial pulse. The EMT starts ventilating her with the BVM connected to oxygen. And after about a minute, maybe even less than that, she begins to breathe spontaneously and is now awake. She's alert and oriented. She's extremely lethargic, though, and she has now progressed to having a skin color that is battleship gray with purple lips. She has no tangible blood pressure. This is not good. There is no sense dallying on scene since we are 40 minutes from the hospital. So reeve stretcher, load her up. I had already called my partner Cam to come back me up. She arrives on scene just as we are getting ready to transport. We both obtain IV access. I put a 16 in her. Now, I am a big 20 gauge is fine for everyone kind of guy, but I figured that she's a surgical disaster and she had pipes. So a big ass conduit for resuscitation is what she got. I give her a fluid bolus because she had no blood pressure. I gave her 500 milliliters of good old-fashioned normal saline. Now, up until a few months ago, I would have given her a 250 bolus, but this is one area where my discussions with Dan Rao, he has changed my mind on this. He told me as far as 250 ml bolus, what's the point? That's a can of Coke as far as volume goes. So I had him in my ear, and I gave her the full 500 ml fluid of bolus. Is that even proper English? I don't know. If you suspect aortic dissection, you do not want them to have too high of a blood pressure. Again, because it will cause the dissection to spread, and eventually it's going to rupture. And if it has already ruptured, it's going to rupture worse. I think people think that patients with aortic dissections, when they rupture, it's just like the garden hose cracking like that, and you start dumping blood and you die. And that certainly does happen. It can happen. But in the patient who is still alive, often it's like the Titanic when it first hit the iceberg. It's just like a little psss of fluid being extravasated. So if they are ruptured and they're still leaking like that, they can be fixed. I mean, they're not necessarily going to die. I mean, certainly they're well on their way, but it is salvageable. Anyway, I'm rambling. You don't want it to progress to a frank rupture. So you don't want the blood pressure to be too high. If you look at 15 different resources, you will find 15 different parameters. If you talk to 5 different CT or vascular surgeons, they will probably give you 5 different preferences for what their blood pressure is. Some sources say to shoot for 90 systolic. Our protocols on the helicopter are no higher than 120 systolic for aortic dissection. Regardless, you don't want them too high. 140 over 90 was too high for this lady. But no blood pressure is also bad because you need to perfuse the brain to keep them alive. So 500 mLs of normal saline she got. I recycled a blood pressure after the fluid bolus, and we now have a blood pressure. It is a balmy blood pressure of 56 over 43. I made the decision to not give her more fluid for now, and I hit her with 10 mics of push dose epi. I think that we can have a debate about whether that was the right thing to do or whether I should have given her more fluid or whether I should have tried another agent, maybe Levophed instead, or maybe whether we should have gone right for blood. But in that moment, that's a decision that I went with. And this is a case study, and hindsight is always 20/20, and this is why we do case studies. So we are doing all of this blood pressure management resuscitation while we're still trying to sort out the friggin' 12 lead cables. Now we weren't getting a tracing period, and we had to run the call off of the pads. We switched out monitors. I took the cables that were on the patient, plugged them into the new monitor, still nothing. And finally I had a light bulb go off, and I thought, hey, maybe it's the original 12 lead cables causing some kind of a short because the monitor was working fine until I hooked up the 12 lead. So switched out the 12 lead cables with Cam's 12 lead cables, and voila, problem solved. And I think it's important to bring this up because this is the stuff that happens in the real world. These are real complicating factors that happen in the real world. And we need to be prepared for technology failures, and we need to be able to work our way through them because they can be a real stumbling block, especially if you're the type of person who suffers from analysis paralysis. So I finally am able to get a 12-lead EKG, and it's a better 12-lead than mine. Picture perfect, beautiful, normal sinus rhythm with virtually zero sign of injury, ischemia, or infarct. This lady is in her mid-80s, and she didn't even have a bundle branch block or axis deviation. It was just beautiful. And that's another lesson. There is no 12-lead finding that indicates aortic dissection. None whatsoever. Actually, this was a point of discussion in an expert witness case that I did. I have seen 12 leads in aortic dissection patients look absolutely horrific. STEMI appearing, spiked helmet sign, and then, like this lady, I've seen them look just perfect. Do not get distracted by the 12 lead EKG. I looked at the 12 lead and I said, well, she's not having a STEMI, and that further helped us to narrow our suspicion for aortic dissection. But honestly, even if it did print out and showed a STEMI, I would have still thought that those ST elevations were due to an angry and injured heart from a dissection, not so much from obstruction in the coronary arteries. A new pressure cycles. I should mention that by this time we are bouncing down the road to the hospital, going lights and sirens. The new blood pressure pops up 87/55. Beautiful. I love that blood pressure for her. In any other patient, I would not love it. But in an aortic dissection patient who I suspect has ruptured and they are mentating, it's a beautiful blood pressure. Years ago, I remember talking on the phone to a CT surgeon on a helicopter transport we did of a patient with a ruptured dissection. And the guy's pressure was low like that. I want to say low 80s, maybe even high 70s. And I remember calling to consult with the surgeon and saying like, hey, I don't want to raise their pressure too much, but their pressure's 70, but they're alert and oriented. And the surgeon said, as long as they're alert and oriented, don't mess with it. Just keep the blood pressure low. I have taken that conversation with me as I have treated patients over the years. So what about blood? The thought did indeed cross my mind. I will be totally honest and transparent with you, though. It crossed my mind on the call, but it really weighed on my mind when hindsight is 20/20 after the call. While on the call, after she had her episode of going unresponsive and she precipitously decompensated, I thought, obviously this dissection has ruptured. She needs resuscitation. But this is where the real world comes into the case study. Right or wrong, I didn't give her blood. Why? Because at the time, I was still kind of vacillating back and forth between what to do. Again, hindsight being 20/20, I probably should have given her the blood rather than a 500 ml bolus. But here I had this patient with hypotension and chest pain. I'm still fucking with the 12 lead, trying to get it to work. And while I was heavily leaning towards dissection versus anything else, there was the little voice in my head telling me, don't be the dumbass who gave a unit of blood to somebody who is having an inferior wall MI. Don't do it until you know what you are working with. And I didn't want to jump the gun. That being said, I do kind of want to kick myself in the balls because I didn't give her blood. If I had to do it again, I'd give the blood. This whole like mental conversation and recycling of the blood pressure and the fluid bolus happened in like 2 or 3 minutes. By the time I got the 12 lead and ruled out STEMI, her blood pressure had risen to a point that was acceptable and shouldn't have been increased further. Blood certainly would have been a better fluid to administer to this lady. You heard Dr. Mark Peel on the podcast here last year, and he was just on the Flight Bridge podcast. It was a great episode, and he talked about the physiologic benefits of blood. And we have beaten that horse. I think it still needs to continue to be beaten because people still amazingly aren't on board with blood. It's one thing for people to say, yeah, we're all about it, but logistically right now we can't do it. We can't financially swing it, or we're still figuring out how we're going to do it. The thing that gets me is that there are still people out there, paramedics, administrators, our doctors, blood bank staff, and physician medical directors, which really surprises me, who are still saying that they don't see the benefit of blood pre-hospitally. And to me, that's just stupid. I really think you need to pull your head out of your ass. But It's not what we're talking about here. Where was I? Yeah, so you heard Mark Peel on the pod. We all know the physiologic benefits of blood, and that would have been better than her getting a 500 ml bolus. Would it have made a difference in her outcome? Probably not. But remember, when we are treating a patient, we are treating what's in front of us. We are not treating what we think is inevitably going to happen. It's not like we are surgeons who have to make the decision. Do we let this patient die or do we surgically intervene? We aren't at that level. We treat what we see, not what we think the outcome is going to be. I have had more than a few patients, and I'm talking overall. I'm not just talking aortic dissection, who I have thought, this is friggin' pointless that we're treating this person. This is a corpse. They just don't know it yet. And I end up being wrong, and they end up surviving and walking out of the hospital. I digress. Let's get back to the transport. I'm not going to give you the EMS charts, page 8, line by line, minute by minute account of what happened during the transport, and not much else changed. Her mental status remained intact, albeit lethargic. She remained hypotensive, but I would call it suspected dissection permissively hypotensive. And she looked like shit. Let's see, a couple of interesting points. I don't like to unnecessarily give my patients oxygen. After she had to be ventilated with a BVM and she started breathing on her own again, we switched her to a non-rebreather mask. During the transport, we transitioned her down to a nasal cannula, and she precipitously dropped her pulse ox to the 70s. And I thought maybe the pulse ox was unreliable because she had no perfusion to her body, but we actually did have a good pleth. And once we put her back on the non-rebreather, she came right back up to 98%. So here's the real interesting thing that happened, and this is pathophysiology at play. During the transport, her JVD got much worse. As her JVD was getting worse, the amplitude of her EKG, the QRS complexes, was getting smaller and smaller. What do hypotension and JVD indicate? Pericardial tamponade. That's Beck's triad. Hypotension, JVD, and muffled heart tones. I didn't listen to her heart tones. Also, suspicious of pericardial tamponade is narrowed pulse pressure, which is where the systolic and the diastolic are awfully close together. And she had this. In one of her blood pressure readings, the systolic and diastolic were only 13 millimeters of mercury apart. And that is because a tamponade causes an inability for the heart to relax and fill with blood. So the heart's pressure at rest is going to be pretty damn close to the same pressure when it's contracting, which is also feeble contractions. Low amplitude QRS complexes can also be caused by pericardial tamponade because there's this big collection of fluid, or blood in her case, covering the heart. You can also get what is called electrical alternans, which she did not have. That is a normal size QRS followed by a little one, and they alternate. Normal size, little, normal size, little. And that happens because of the fluid accumulation around the heart that causes the entire pericardium to kind of become heavy, and it sways back and forth in the chest cavity towards and away from the EKG like a pendulum. Don't quote me on this. We had her supine. I think that's more common if they're sitting up in a Fowler's position because of gravity, but we didn't try to sit her up in the Fowler's position to see if she had electric alternans. That would have been stupid. Anyway, this lady did indeed have a ruptured aorta. She had dissected, she sprung a leak, and she was pouring blood into her chest, including her pericardial space. Aortic dissection patients commonly develop cardiac tamponade and left-sided pleural effusions. Citation in the show notes. I'm going to butcher these one of these Japanese last names. I apologize. Tsukubi and Okita 2017. Cardiac tamponade is a common fatal complication of type A. That is a dissection that involves the arch. Type B does not involve the arch. That would be called a descending aortic dissection. But cardiac tamponade, common fatal complication of type A dissection because the aorta dissects into the pericardial space. There are 8 to 31% incidence of tamponade in type A dissection, and they write that many of these patients die before reaching the hospital. in-hospital mortality is 54%. So the fact that this lady survived the transport is a miracle in of itself. A dissection involving the arch is much worse than a descending type B dissection. Those are still very bad, but a type A dissection is much worse. These patients have extremely high mortality, and the surgery is very, very complicated with a lot of downstream complications if they survive the procedure. Even if this lady was 50, her risk of dying would have been very high, along with having a very complicated course of stay in the hospital if she survived. Unfortunately for her, her age is a force multiplier for the Grim Reaper's army. So we get her to the hospital alive, blood pressure's in the 80s, put her into a resus room. They put a probe on her chest, and even I, with very limited ultrasound training and one who has never used it pre-hospitally because I don't have it in my protocols, even I could see a dissection flap and that she had massive pericardial effusion, the cardiac tamponade. So I get follow-up on her later that night. They did take her to surgery. I don't know how she did. If I were a betting man, I would say that I will read her obituary in a couple of days, but I have been wrong before. I hope I am. But here's the radiology report. Acute rupture of ascending thoracic aorta. Active extravasation and hematoma formation surrounding the thoracic aorta. There is hemopericardium, so she is pouring blood into her chest cavity and has a cardiac tamponade. The dissection, according to the report, extended into the left subclavian artery. You often see that dissection spread into other major arteries. I've had it before where it's spread into the subclavians. Renal arteries is very common. Carotid arteries is very common. So if you get these patients with this tearing chest pain and altered mental status that's not due to frank hypoperfusion, or they have stroke symptoms, you can take it to the bank that the carotid arteries have also dissected and blood flow to the brain has been affected. This lady's dissection flap terminated in the mid to lower descending thoracic aorta. So this thing ripped basically from her heart to her asshole. Not good. That's an interesting case. That is about as sick as a human being can get. I have talked, as I said, about this on a couple of podcasts. And like I said, this is one of my favorite topics. I like taking care of these patients because they are such train wrecks and they are labor intensive and they require higher level critical thinking than a lot of other patients that we take care of. Let's talk about some take home points. Mortality is high, overall 25 to 50% depending on age, comorbidities. And that number comes with the caveat. That is a subsection of overall patients with an ascending aortic dissection. Remember, 50% overall die before they get to the hospital or can call 911. That being said, yes, with age comes more mortality, but these patients can and do survive. CT surgeons make a shitload of money for very good reason because they're very good at what they do, and what they do is extremely complex. So in these patients, understand they do indeed have one foot in the grave, another on a banana peel. There is great gravity in what we do. How we manage these patients pre-hospitally matters. And in many of these patients, though, there is a very real chance that if you can get them to the hospital, they've got a fighting chance to survive. Those surgeons can really do some magic, but it's not going to be easy. And even if they survive the surgery, they're not out of the woods, but they can and do survive. So to end, let's rapid fire review some learning points that I took away and that I want to share from this particular patient. 1, be suspicious with any patient who tells you they have tearing pain in the back. That is a textbook finding. 2, remember that there are a wide array of problems that will cause chest pain. This is one of them. If you suspect an aortic dissection, and again, you won't suspect it if you aren't educated on it, it's not covered in EMT education. I think the paramedic education does a poor job covering it. So that is one reason that I like to talk about it here, because EMS providers need to know about it. 3, these patients will usually be very hypertensive and in excruciating pain. You need to treat their pain. That's another thing I didn't talk about. We didn't give this lady any pain meds. One, she was so hemodynamically unstable. I don't think, as much as I love ketamine, I don't think that that's an optimal agent to use in a patient with an aortic dissection, because that will cause a catecholamine release that will increase their heart rate and blood pressure, which is the exact opposite of what you want. Per protocol, we couldn't give her any fentanyl because her blood pressure was too low. But I will say that mercifully for her, after she said it's getting worse, and I think that the dissection really spread, and that's when she ruptured. If I were a betting man, she actually was pretty comfortable and said that her pain wasn't as bad as it had been. So otherwise, you do need to treat their pain. You definitely need to treat their hypertension if it is within your protocols. Normotension in these patients is an ominous finding. Hypotension is a drastically bad finding and almost certainly means that the dissection has ruptured and that they are bleeding into their chest. Which pressor to use in these patients, I don't know. I asked my old medical director about a patient like this, and I asked him, what pressor would you have chosen? And his response was, this patient didn't need a vasopressor, they needed a pine box. 4, don't over-resuscitate hypotension. Follow your local protocols, but as far as a teaching point here, treat the blood pressure only enough to perfuse the brain. They are likely going to have kidney damage anyway due to the development of false lumens, which I'm not going to cover here. I do cover that in the Rippin' Aortas podcast. 5, pericardial tamponade is a leading cause of death in the patient with an ascending aortic dissection. No Beck's triad, hypotension, JVD, and muffled heart tones. You probably won't hear muffled heart tones because we suck at listening to heart tones and you're bouncing down the road. But do know that the tamponade can muffle the QRS complex and cause low voltage QRS. Also look for narrow pulse pressures. And 6, there are no 12 lead EKG findings that suggest rule in or rule out aortic dissection. The EKG to repeat could be glaringly horrific, or it could be picture perfect in a patient who is absolutely dying. Anyway, very nice lady. I hope she did well. I bet that she did not. Very sick lady, but definitely a good case to talk about, good lessons to learn, things to be aware of. And I like doing these podcasts where I get to share real world cases with you, because there's things that I do well. There's things that I think I could do better. And I think that we need to share these experiences so that we can learn from them and have honest conversations. You're going to hear a great, here's a plug, debrief podcast coming up for the surgical airway call that I had. A lot of you know that I did my first crike in 23 years. And it was a shit show call. I think it was like a once in a career type call. I know a bunch of people have done crikes. I'm not trying to put myself up here on top, but a lot of them were like old people choking on food, stuff like that. I would say that the good Lord upstairs probably provided me with a worst case scenario to do a crike. The only thing that could have been worse was if this patient was morbidly obese. He wasn't, thank God. There's a lot to learn from this call and a lot to unpack, and we are going to debrief it. We actually already did. My partner Cam came on, and we had Haney Malamat come on to the podcast, and we debriefed the call. And you're going to hear stuff like you heard today, what we did really well, and stuff that I don't think that we did that well or that we could have done better. And again, you will always hear these type of honest conversations. I don't like the case studies. I would hear that a lot on podcasts where it would be these either sterile case studies that fit into these nice packages, or I would hear case studies where it was kind of like, look how awesome we are. And we are awesome, but we fuck up. And we need to talk about that and share that. I'm going to stop rambling because it's Sunday night. I'm off, and Ashley and I are going to go out to dinner. And thanks for tuning in. Thanks for listening. And I will talk to all of you soon.